Hello, dear students. My name is Irina Stasyuk, and I'm happy to give your consideration the lecture called The Ethical and Deontological Aspects of Family Doctor's Activity by the Department of General Practice, Family Medicine of Zaporizhia State Medical University. Medical ethics is the system of moral principles that apply moral values and judgments as they apply to the practice of medicine. The medical ethics encompasses its practical application in clinical settings, as well as work in its history, philosophy, theology, and sociology. Medical ethics tends to be understood narrowly as an applied professional ethics, whereas bioethics appears to have worked more expansive concerns, touching upon the philosophy of science and issues of biotechnology. Still, the two fields often overlap, and the distinction is more a matter of style than professional consensus. Medical ethics shares many principles with other branches of healthcare ethics, such as nursing ethics. Six of the values that commonly apply to medical ethics discussions are autonomy. The patient has the right to refuse or choose their treatment. Beneficence. A practitioner should act in the best interest of the patient. Non-maleficence. First, do no harm. Justice concerns the distribution of scarce health resources and the decision of who gets what treatment. Dignity. The patient and the person treating the patient have the right to dignity. Truthfulness and honesty. The concept of informed consent has increased in importance since the historical events of the doctor's trial of the Nuremberg trials and Tuskegee syphilis study. The principle of autonomy recognizes the rights of individuals to self-determination. This is rooted in society's respect for individuals' ability to make informed decisions about personal matters. Autonomy has become more important as social values have shifted to define medical quality in terms of outcomes that are important to the patient rather than medical professionals. The increasing importance of autonomy can be seen as a social reaction to a paternalistic tradition within healthcare. Some have questioned whether the backlash against historical excessive paternalism in favor of patient autonomy has inhibited the proper use of soft paternalism to the detriment of outcomes for some patients. Respect for autonomy is the basis for informed consent and advanced directives. Autonomy is a general indicator of health. Many diseases are characterized by loss of autonomy. This makes autonomy an indicator for both personal well-being and for well-being of the profession. This has implications for the consideration of medical ethics. Is the aim of healthcare to do good and benefit from it, or is the aim of healthcare to do good to others and have them and society benefit from this? Ethics tries to find a beneficial balance between the activities of the individual and its effects on a collective. Psychiatrists are often asked to evaluate a patient's competency for making life and death decisions at the end of life. Persons with a psychiatric condition, such as delirium or clinical depression, may not have the capacity to make end-of-life decisions. Therefore, for these persons, a request to refuse treatment may be ignored. Unless there is clear advance directive to the contrary, persons who lack mental capacity are generally treated according to their best interests. On the other hand, persons who have the mental capacity to make end-of-life decisions have the right to refuse treatment and choose an early death if that is what they truly want. In such cases, psychiatrists should be a part of protecting that right. Beneficence. The term refers to actions that promote the well-being of others. This means taking actions that serve the best interests of patients. However, uncertainty surrounds the precise definition of which practices do, in fact, help patients. The beneficence is the only fundamental principle of medical ethics. They argue that healing should be the sole purpose of medicine, and that endeavors like cosmetic surgery, contraception, and euthanasia fall beyond its purview. Non-maleficence. The concept is embodied by the phrase "first do no harm." Many consider that should be the main or primary consideration, that it is more important not to harm your patient than to do them good. This is partly because enthusiastic practitioners are prone to using treatment that they believe will do good, without first having evaluated them adequately to ensure they do no harm, or only acceptable levels of harm. Much harm has been done to patients as a result. It is not only more important to do no harm than to do good, it is also important to know how likely it is that your treatment will harm a patient. So a physician should go further than not prescribing medications they know to be harmful. He or she should not prescribe medications or otherwise treat the patient unless she knows the treatment is unlikely to be harmful, or at very least that patient understands the risks and benefits, and that the likely benefits outweigh the likely risks. In practice, however, many treatments carry some risk of harm. In some circumstances, e.g., in desperate situations where the outcome without treatment will be grave, risky treatments that stand a high chance of harming the patient will be justified, as the risk of not treating is also very likely to do harm. So the principle of non-maleficence is not absolute, and balances against the principle of beneficence, doing good, as the effects of the two principles together often give rise to a double effect. Non-maleficence is defined by a cultural context. Every culture has its own cultural collective definitions of good and evil. Their definitions depend on the degree to which the culture sets its cultural values apart from nature. In some cultures, the terms good and evil are absent. For them, these words lack meaning, as their experience of nature does not set them apart from nature. Other cultures place the humans in interaction with nature. Some even place humans in a position of dominance over nature. The religions are the main means of expression of these considerations. Depending on the cultural consensus conditioning, the legal definition of non-maleficence differs. Violation of non-maleficence is the subject of medical malpractice litigation. Regulations thereof differ, over time, per nation. Ethics of justice, also known as morality of justice, is the term used to describe the ethics and moral reasoning common to man and preferred by Kohlberg's stages of moral development. The ethics of justice deal with moral choices through a measure of rights of the people involved and chooses the solution that seems to damage the least number of people. Dignity is a term used in moral, ethical, and political discussions to signify that a being has an innate right to respect and ethical treatment. It is an extension of Enlightenment era beliefs that individuals have inherent, inviolable rights, and it is so thus closely related to concepts like virtue, respect, self-respect, autonomy, human rights, and enlightened reason. Dignity is a precondition of freedom. It is generally prospective and cautionary. In politics, it is usually synonymous to human dignity and is used to critique the treatment of oppressed and vulnerable groups and peoples, though in some cases has been extended to apply to cultures and subcultures, religious beliefs and ideas, animals used for food or research, or even plants. In more colloquial settings, it is used to suggest that someone is not receiving a proper degree of respect, or even that they are failing to treat themselves with proper self-respect. Much of the 20th century, dignity appeared in assorted writings as a reason for peacemaking and for promoting human rights. For example, the Universal Declaration of Human Rights, adopted by the United Nations General Assembly on December 10, 1948, states, Article 1. All human beings are born free and equal in dignity and rights. They are endowed with reason and conscience and should act towards one another in a spirit of brotherhood. Article 2. Everyone is entitled to all rights and freedoms set forth in this declaration, without distinction of any kind, such as race, color, sex, language, religion, political or other opinion, national or social origin, property, birth, or other status. Furthermore, no distinction shall be made on the basis of the political, jurisdictional, or international status of the country or territory to which a person belongs, whether it is independent, trust, non-self-governing, or under any other limitation of sovereignty. In the 20th century, dignity became an issue for physicians and medical researchers. It has been invoked in questions of bioethics, of human genetic engineering, human cloning, and end-of-life care. Truthfulness and honesty. Values such as these do not give answers as how to handle a particular situation, but provide a useful framework for understanding conflicts. When moral values are in conflict, the result may be an ethical dilemma or crisis. Sometimes no good solution to a dilemma in medical ethics exists, and occasionally the values of the medical community can conflict with the values of the individual patient, family, or larger non-medical community. Conflicts can also arise between healthcare providers or among family members. Some argue, for example, that the principles of autonomy and beneficence clash when patients refuse blood transfusions, considering them life-saving, and truth-telling was not emphasized to a large extent before the HIV era. Double effect refers to two types of consequences which may be produced by a single action, and in medical ethics it is usually regarded as a combined effect of beneficence and non-maleficence. A commonly cited example of this phenomenon is the use of the morphine or other analgesic in the dying patient. Such use of morphine can have the beneficial effect of easing the pain and suffering of the patient, while simultaneously having the maleficent effect of hastening the demise of the patient through suppression of the respiratory system. Autonomy can come into conflict with beneficence when patients disagree with recommendations that healthcare professionals believe are in the patient's best interest. When the patient interests conflict with the patient's welfare, different societies settle the conflict in a wide range of manners. Western medicine generally defers to the wishes of a mentally competent patient to make his own decisions, even in cases where the medical team believes that he is not acting on his own best interests. However, many other societies prioritize beneficence over autonomy. Examples include when a patient does not want a treatment because of, for example, religious or cultural views. In the case of euthanasia, the patient or relatives of the patient may want to end the life of the patient. Also, the patient may want an unnecessary treatment, as can be the case of hypochondria. A doctor may want to prefer autonomy because refusal to please the patient's will would harm the doctor-patient relationship. Individuals' capacity for informed decision-making may come into question during resolution of conflicts between autonomy and beneficence. The role of surrogate medical decision makers is an extension of the principle of autonomy. On the other hand, autonomy and beneficence non-maleficence may also overlap. For example, a breach of patient's autonomy may cause decreased confidence for medical services in the population, and subsequently less willingness to seek help, which in turn may cause inability to perform beneficence. The principles of autonomy and beneficence non-maleficence may also be expanded to include effects on the relatives of patients or even the medical practitioners, the overall population, and economic issues when making medical decisions. Some American physicians interpret the non-maleficence principle to exclude the practice of euthanasia, though not all concur. In some countries, euthanasia is accepted as standard medical practice. Legal regulations assign this to the medical profession. In such nations, the aim is to alleviate the suffering of patients from diseases known to be incurable by the methods known in that culture. In that sense, the primum non nocere is based on the realization that the inability of the medical expert to offer help creates a known great and ongoing suffering in the patient. Not acting in those cases is believed to be more damaging than actively relieving the suffering of the patient. Evidently, the ability to offer help depends on the limitation of what the practitioner can do. These limitations are characteristic for each different form of healing and the legal system of the specific culture. The aim to not do harm is still the same. It gives the medical practitioner a responsibility to help the patient in the intentional and active relief of suffering in those cases where no cure can be offered. Informed consent in ethics usually refers to the idea that a person must be fully informed about and understand the potential benefits and risks of their choice of treatment. An uninformed person is at risk of mistakenly making a choice not reflective of his or her values or wishes. It does not specifically mean the process of obtaining consent, nor the specific legal requirements, which vary from place to place, for capacity to consent. Patients can elect to make their own medical decisions or can delegate decision-making authority to another party. If the patient is incapacitated, laws around the world designate different processes for obtaining informed consent, typically by having a personnel appointed by the patient or their next of kin make decisions for them. The value of informed consent is closely related to the values of autonomy and truth-telling. A correlate to informed consent is the concept of informed refusal. Confidentiality is commonly applied to conversations between doctors and patients. This concept is commonly known as patient-physician privilege. Legal protections prevent physicians from revealing their discussions with patients even under oath in court. Confidentiality is mandated in America by laws. However, numerous exceptions to the rules have been carved out over the years. For example, many states require physicians to report gunshot wounds to the police and impaired drivers to the Department of Motor Vehicles. Confidentiality is also challenged in cases involving the diagnosis of a sexually transmitted disease in a patient who refuses to reveal the diagnosis to a spouse, and in the termination of a pregnancy in an underage patient without the knowledge of the patient's parents. Traditional medical ethics has viewed the duty of confidentiality as a relatively non-negotiable tenet of medical practice. More recently, critics like Jacob Appel have argued for a more nuanced approach to the duty that acknowledges the need for flexibility in many cases. Many so-called ethical conflicts in medical ethics are traceable back to a lack of communication. Communication breakdowns between patients and their healthcare team between family members, or between members of the medical community can all lead to disagreements and strong feelings. These breakdowns should be remedied, and many apparently unsurmountable ethics problems can be solved with open lines of communication. It is a more important factor in it. To ensure that appropriate ethical values are being applied within hospitals, effective hospital accreditation requires that ethical considerations are taken into account. For example, with respect to physician integrity, conflicts of interest, research ethics, and organ transplantation ethics. Cultural differences can create difficult medical ethics problems. Some cultures have spiritual or magical theories about the origins of the disease, for example, and reconciling these beliefs with the tenets of Western medicine can be difficult. Some cultures do not place a great emphasis on informing the patient of the diagnosis, especially when cancer is a diagnosis. American culture rarely used truth-telling, especially in medical cases, up until the 1970s. In American medicine, the principle of informed consent now takes precedence over other ethical values, and patients are usually at least asked whether they want to know the diagnosis. The delivery of diagnosis online leads patients to believe that doctors in some parts of the country are at the direct service of drug companies. Finding diagnosis as convenient as what drug still has patient rights on it. Physicians and drug companies are found to be competing for top 10 search engine ranks to lower costs of selling these drugs with little to no patient involvement. Physicians should not allow a conflict of interest to influence medical judgment. In some cases, conflicts are hard to avoid, and doctors have a responsibility to avoid entering such situations. Unfortunately, research has shown that conflicts of interest are very common among both academic physicians and physicians in practice. For example, doctors who receive income from referring patients for medical tests have been shown to refer more patients for medical tests. Fee splitting and the payments of commissions to attract referrals of patients is considered unethical and unacceptable in most parts of the world. Studies show that doctors can be influenced by drug company endorsements, including gifts and food. Industry-sponsored continuing medical education programs influence prescribing patterns. Many patients surveyed in one study agreed that physician gifts from drug companies influence prescribing practices. A growing movement among physicians is attempting to diminish the influence of pharmaceutical industry marketing upon medical practice, as evidenced by Stanford University's ban on drug company sponsors, lunches, and gifts. Many doctors treat their family members. Doctors who do so must be vigilant not to create conflicts of interest or treat inappropriately. Sexual relationships between doctors and patients can create ethical conflicts, since sexual consent may conflict with the fiduciary responsibility of the physician. Doctors who enter into sexual relationships with patients face the threats of deregistration and prosecution. In the early 1990s, it was estimated that from 2 to 9% of doctors had violated this rule. Sexual relationships between physicians and patients' relatives may also be prohibited in some jurisdictions, although this prohibition is highly controversial. Thank you for your attention.